Welcome to a new episode of IBD Essentials. We are gaining more and more interest in the recent month, and so it's a great pleasure today to meet a great friend and colleague, Bruce Sands. We have a long way together, and we will hopefully have a wonderful discussion today. If you like this, and if you have other interesting topics, because Bruce is really a great friend, we can talk in the future several times. Just give us some likes, send us some topics you would like to have discussed. And Bruce, it's really wonderful. I just mentioned we have been working together probably 30 years ago when we were both in Boston as fellows.
And very young.
And very young and very beauty.
Full of energy.
Full of energy. And I think it would be very interesting for our listeners and viewers just to listen to your biography, because we both started in the lab, did basic research, and now you are probably one of the most eminent clinical physicians leading a lot of trials. So how was this way? Why did you choose this way and did not stay in basic science, staying at the lab bench?
Yeah, I guess it's words of encouragement for people who start in the lab and decide they want to do other things, which I think is okay for some people. We were both at Massachusetts General Hospital at the same time in the laboratory, overlapping some. Actually, you arrived just as I was starting to leave the laboratory. And, our division chief, Dr. Daniel Podolsky, renowned gastroenterologist, he attracted me to his lab. I was doing my full GI training there. And I did it for a couple of years. I enjoyed the work. I liked it. I can't say that I liked working with mice. That was never a fun thing for me. But I was successful. At that time, I'd cloned intestinal trefoil factor gene, which the lab was working on now, called TFF3, turned out to be important for Barrett's esophagus potentially, but not too much for IBD probably. Around 2 years into it, my first son was born, and that made me introspect quite a bit about what I really felt about my laboratory experience. And what I really missed was the direct relevance to the patients. And so then I went to Dan Podolsky and I said, I like investigation, but I really think I want to turn it to clinical investigation to be closer to the patient. There were no examples of anyone doing that in IBD in that division. There was a hepatologist, Jules Dienstag, who is still there at Harvard Medical School. He was doing that for liver disease, but no one else was a clinical investigator. But, he was a good mentor. He could have told me, okay, if that's what you want to do, out of the lab, out of training, bye-bye. But he instead said, okay, if that's what you want to do, take some coursework at Harvard School of Public Health, learn about clinical research now instead of laboratory research. And then when I came back, he put me on my first clinical trial, which was a study of CA2 in ulcerative colitis and CA2 in Crohn's disease. Well, CA2 turns out to be infliximab. So I was very fortunate to get in on the ground floor of the biologic revolution that we saw over the last 30 years in inflammatory bowel disease. And from there, I've just been very fortunate to continue to work in that area. And of course, we've seen an explosion of treatments for IBD.
Yeah, and now you are in New York, Mount Sinai, so the head of the IBD world, probably. How did it come that you were moving to Mount Sinai, not staying in Boston? Massachusetts General Hospital offered everything. We had a lot of research money there.
It's true. I could have stayed very happily at Mass General for my whole career. But at some point, Dan Podolsky left to be president of UT Southwestern, president of a university. So really remarkable career path. And when he left, I was asked to be the acting chief or the interim chief for the division that I grew up in. And so I tried that leadership role. I didn't know if I would like it. People told me I was good at it, and I kind of enjoyed it, actually. And then Mount Sinai called. And of course, Mount Sinai has a historic name, the home of Burl Crone. So that got me to look. And they made a commitment to really build IBD there because a lot of what was going on in inflammatory bowel disease at Mount Sinai at that time, if you remember Dan Present,
Yeah.
he was a clinician. He was not a full-time employed faculty member. So the institution really wanted to build up IBD, and that's partly why it was brought there. So it was just an incredible opportunity to build something
Yeah.
with a historic name, but a
Yeah.
lot of building had to
Yeah,
be
and I
done.
think now you have really tremendous opportunities. You have the full breadth of IBD, covering everything from surgery to pediatric IBD, basic research, and you have exciting people there. We are both members of the IOIBD, and there are several other members from Mount Sinai in
More
the
from Mount
IOIBD.
Sinai than
So,
from anywhere else in the
yeah,
world, I
so
think.
I think it's really a good place to stay, or?
Absolutely, yeah. There's no place like it.
And we have seen also in the past a lot of evolvements now in the treatment goals we have for IBD. We have seen numerous agents, and you mentioned your first trial. So this was from the pre-biologic era to the biologic era. Since then, our tools have expanded significantly, but we still talk about the ceiling which we cannot break, and we are probably not working in the wrong field. I always say it's the best field,
For sure.
because we have exciting diseases. But if it would be dermatologists, there is the ceiling already. Probably if we are there over the ceiling, they can almost cure their disease, and we have a lot of drugs in our armamentarium, but we reach for difficult to treat patients like a level of 50% or 60%, sometimes only 40%. And you are really into the field, and you were also really thinking about combination of treatments, because personally I believe this may be a mistake we are doing. If we look to oncology, for instance, there is almost no monochemotherapy, it's combination
Right.
therapy, and this is probably something we really need to go into, at least with the drugs we have in our hands now, or?
Yeah, no, I agree completely. If you look at how much progress we made, it's been very substantial. But if we talk about each of the monotherapies that we have, we see there's a lot of room for improvement. We talk about this therapeutic plateau. If you think about it, there are a few different ways to overcome that plateau. One is it's very clear that we're not using the medications we have in the most effective way. The profile study, once again, after the step up, top down study that Gert Dans did more than 20 years ago already, once again demonstrates that if you use effective medications early in the course of Crohn's disease, you really can transform the downstream effects of the disease and really change the disease profile over time. But the truth is, a lot of patients don't get to that effective therapy as quickly as they should for a large variety of reasons: the cost of care, lack of access to care, their own beliefs about whether they want to take a chance on aggressive therapy in their mind of, infliximab and azathioprine. So there are a lot of reasons why that doesn't happen. And then we're left with a lot of patients who are much more refractory. So I think once we get beyond the early application of effective therapy, we have to start thinking in a few different ways. Sure, it's still possible we might find that novel mechanism of action that will really achieve what the anti-IL-17s have done in psoriasis, for example,
Yeah.
and the anti-IL-23s. But that hasn't been achieved yet with the monotherapy, and it's not for lack of trying. We've tried lots of different mechanisms,
Yeah.
but no single one has yet done it.
But is there probably also a problem that we have a disease where people usually do not die? So this is probably a major difference to cancer. And
Sure.
you just mentioned the problems of the initial combination therapy. Combination was going along with more side effects, reduced safety. And now with all the new drugs we have in our hands, a lot of them are safe,
It's true.
and they really offer to be combined, probably.
Combined, or you could also imagine these safer medications also being applied in early Crohn's disease might also be transformative, but we haven't seen these studies conducted yet. So we'll have to see in the future if that is equally good as infliximab plus azathioprine for Crohn's disease. But I think if you think about other ways, so let's assume we're not close to identifying that amazing, transformatively
The
effective
magic bullet.
monotherapy, the magic bullet. And I think part of that may be the heterogeneity of the diseases that we're treating. The other approaches might be using predictive biomarkers, a precision medicine approach. If you could pick a subpopulation who by some test you can identify as having that transformative efficacy with one mechanism of action, you would surely want that. That would be great for certain segments. And of course, you'd like to have all segments of the population broken out so that you knew exactly which things. But think of how difficult that can be in inflammatory bowel disease, which is, again, I think a lot more heterogeneous than many cancers, for example.
Yeah, I think we do not have the real endotypes, and you brought it to a very important point. We would need predictive biomarkers, and at least as I believe, at the moment we do not have the real predictive biomarkers. We know the missed success with the profile data. Just recently we were seeing the Nordtreat data from Scandinavia, from Sweden. Again, these biomarker profiles, protein profile, didn't work out. Numerous groups, industry, they're all working on in this area. So this would be probably the great tool, and would be also the great tool to stop that we do overtreatment, because you just mentioned top down is, at least for Crohn's disease, the thing we have to do. But remember 20 years back, there was a lot of fighting that we would have overtreatment because we would need to treat patients that would not need that severe type of treatment. And I think it's all because of lack of predictive biomarkers, or?
I think that's right. So there are biomarkers that might predict prognosis, and that would help in the situation that you're talking about. Who's going to have a mild course of disease and who's going to have an aggressive course of their Crohn's disease. The truth is 80% will have that aggressive course. So I guess you're over-treating 1 in 5 patients if you do top down potentially. Not an issue if the drug is safe. But the other kind of biomarker is the predictive biomarker for drug response. And mostly where we have had success, it's to predict non-response. Oncostatin M would be a good example, non-response to anti-TNFs. It doesn't help us as much to know what they're not going to respond to. What we need to know is what they're going to respond to. And you could also say you could have predictive biomarkers, and we do have some of these, of negative effects of medication, so side effects. So we have this with NUD15, for example, predicting leukopenia or thiopurine methyltransferase.
Yeah, exactly. I think this is also important, not to use those drugs that will cause certain side effects in a very high frequency. So this is also very helpful. But if we move along,
there's one more way.
There are several more ways. I would say we could diagnose earlier. We could find the cure by knowing what is causing the disease. But for the moment and for now, I think combination is something which is very good. And I personally always say we now talk about combination as we are reinventing the wheel. We are probably reinventing the wheel if we combine advanced therapies, but combination has been used for 40 years. When we go back to even 5-ASA, we have a combination of rectal and oral formulations.
That's right.
Combine steroids with everything because we know they are really acting fast, but for the long-term treatment, not perfect. And you have very nice concepts how you can combine therapy, because a lot of people think combination is just combining two things at the same time, but there are other ways, or?
Yeah, there are many different paradigms in which you can view lenses through which you can view combination therapy. So you mentioned combining 5-ASAs, oral and rectally administered. Well, that's a pharmacokinetic combination. I think mostly what we're thinking of as overcoming that plateauing is pharmacodynamic combinations, which are synergistic or additive. They do more than either one alone, at least additive, but we prefer even more than that, multiplicative. So those are two big frameworks, but I think the bigger way to conceptualize it is through timing. So if you think of how we might combine things, if we think of induction phase and maintenance phase, and induction, you might start with drug A, And if there's a partial response, then you layer on drug B. And I think we do this quite a bit actually in practice already, not having well studied it, but we do it just because it's practical. It's possible, and we could talk about this, combining everything from the beginning. So an example of this historically would be when we begin methotrexate and an anti-TNF together. We're doing that in part because we're preventing immunogenicity, but also we're improving the drug clearance, reducing the drug clearance of the anti-TNF. We're doing two things at once, but that also probably is more of a pharmacokinetic play
Yeah.
than a pharmacodynamic play. And then, it's possible to start together, but in maintenance, peel one of the combination off and maintain with one, presumably the safer of the two. So we see examples of this being studied, for example, combinations of JAK and something safe like an anti-integrin.
Yeah.
Doing that in the beginning, the JAK boosts the inductive efficacy, and then the idea is the safer thing for the long term might be the anti-integrin, and that's what you continue long term.
Yeah, and at the recent meetings, we exactly have seen this data really showing that there is higher efficacy, and if we start very hard and very early, and then we have probably no safety issues because it's a short amount of time, and for the long-term treatment, we move to other therapies. Probably a very, very good approach. This is one approach you were considering. But we have now so many drugs in stock. So how would the clinician or the scientist select drugs which can be combined? Just using different mechanisms or different speeds or?
Yeah, I mean, there are so many different permutations of the things that we have available. Every time we add another mechanism of action, you add on multiple different possible combinations. They can't all be studied. So we have to take our best shots in trials. I think there are probably laboratory-based ways, in silico ways even, that might predict which combinations are more likely to be successful and safe. Because we can't study everything in combination. Animal models might also provide some information about which combinations are worthwhile. But then I think we just have to use our common sense about what makes sense to combine. And I think mainly these days, we're not only looking for efficacy. We have so many safe medications, we're also looking for safety as well.
Yeah, and you really did one of the first combination trials, I don't know, 15 years, 20 years ago, an anti-integrin we do not use now because of the very severe side effects, natalizumab, with an anti-TNF, just a proof of concept trial. And now we have so many other different combinations, and I think this is a very good combination, probably an anti-integrin, but anti-integrin combined with an anti-TNF.
Anti-cytokine, or more generally,
But we have
anti-TNF
seen
in particular.
anti-TNFs with IL-23 blockers, for instance. We have even seen triple therapy, like the pilot study by Jean-Fred Colombel, Meteor, where we have a threefold combination therapy.
Yeah.
So where is the end?
Well, we need more information. Sure, we are racking up lots of N of 1 studies, case series of this or that combination. So that is some evidence, more for the safety than the efficacy, I think, over time. But I think we have to study our best shots, the best combinations that we can conceive of. So, of course, we have the Vega study, and that really ignited a lot of excitement. That, of course, was a relatively naive population of patients with ulcerative colitis, your classic moderately to severely active UC. And these patients were either going to get an anti-TNF, golimumab, or an anti-IL-23, guselkumab, or the combination. So a very easy to understand study. You know what monotherapy of each of them would do in comparison to the combination. And this was based, again, on in silico experiments and laboratory data suggesting that the combination actually hits more pathways than either one alone. And so it expands. It really is almost like a different MOA when you combine things that have some synergy. And of course, you know the result, that actually for the most rigorous outcomes of endoscopic outcomes, there was a near doubling of either monotherapy.
But this also brings me to an important question, because I like this trial and I think this was very stimulating. And there is another important point. If you combine, for how long do you combine? If you
Right.
do it very long, if you have very two safe drugs, would be probably appropriate. Here you have an anti-TNF where you may think it may have some side effects. But in this trial, I was not perfectly convinced. The time period of 3 months for a drug, which usually needs like 3 months to act, was, in my opinion, too short. Any opinions on this?
Yeah, I think, you saw that the combination arm then moved to guselkumab as maintenance, and there was good maintenance effect after that. So this raises the question, do you just need the boost in the beginning and then use something effective to maintain after that? That's one paradigm. I think we'll see another step in this when we see the duet studies reported out. Different studies, same principle, same combination being studied. But now we're expanding to duet CD, so that's Crohn's disease, which was not studied. And in UC, duet UC, both of these are looking at patients who had failed other things, other advanced therapies. And so you're going to see a more refractory patient population studied, and you'll also see what the long-term effects of the combination would be.
So before we come to a close, I think one, for me at least, very exciting aspect, and also for patients, is combined therapies. So dual antibodies, for instance, the biclonal antibodies, they can bind two different sites. And then if you have them in an oral way, as you mentioned with the duet studies, this is something which is probably also favorable for our patients. Where do you believe it will be going? Like triclonal antibodies, making it even simpler?
Yeah, those bispecific antibodies and trispecific and maybe even more are very intriguing because they're a way of achieving a combination without having to administer two drugs or mix two drugs and co-administer them, which is essentially what's being done in the duet studies. And I think they're not exactly the same thing though, because here you have on one molecule binding to two different targets, which may be in very different places, in different concentrations, and it may be a tough needle to thread to make sure that you have a concentration that hits both targets, or let's say even three targets adequately. So while these things are, I think, approved and used in oncology, we have yet to see an approved example or even a studied example, fully studied in phase 2 at least, of a bispecific.
I think this was really beautiful to talk with you, and I think for our listeners also very good point that you can make a big career even if you change your pathway, and you don't need to stick the certain point when you are young. And it's always a pleasure to discuss with you and meet with you, and I think we should make several of these podcasts in the near future. Bruce, thank you so much.
Thank you, Axel.
And I wish you had also an enjoyable discussion and listening to us. If you really like us, please like us, and more episodes to come in the very near future. Thank you so much.